In Tune. Conversations on audiology and balance. An Inventis podcast.
Disclaimer. This podcast is intended primarily for the scientific community and healthcare professionals, and is provided for informational and educational purposes only. Any references to medicinal products, active substances, therapeutic indications, or treatment strategies are made solely within the context of scientific discussion and should not be interpreted as therapeutic recommendations or clinical guidance. All clinical decisions, including the prescription of medications, remain the sole responsibility of the treating physician, based on the individual clinical evaluation of each patient. The authors, guests, and producers of this podcast disclaim any liability arising from the improper use or interpretation of the information presented in this episode.
Welcome to this new episode of our podcast dedicated to vestibular medicine. Today, we have the great pleasure of welcoming Dr. Maurizio Bavazzano. He is an ENT specialist at the Department of Otolaryngology of the San Matteo University Hospital in Pavia, Italy. He has been a speaker at numerous national and international conferences and seminars. For many years, he has collaborated with Inventis as a speaker for the Academia project, where he has presented several webinars, including the Epidemiology of Vertigo and Phobic Vertigo. Good morning, Doctor.
Good morning, Mario. It's a pleasure to see you again and to be your guest once more. Over the years, I've built a special friendship with Inventis, so I'm truly happy to be here again.
And we're very happy to have this collaboration as well. Let's get started. I'd like to begin by asking how your interest in vestibular medicine first developed and why you decided to focus in particular on pharmacological therapy.
Well, my passion for vestibular medicine goes back a long way. I actually wrote my specialization thesis on vestibular medicine many years ago. Then, over the years, depending on my work in the hospital, I followed the field more or less closely. But for the past 10 years, I've been fully dedicated to it. Nowadays, I work almost exclusively in vestibular medicine. That's an interesting question. Why did I choose to focus on pharmacology? The answer is actually very simple. It may sound like an anecdote, but it's absolutely true. A few years ago, a colleague and friend of mine, I'll even mention his name, Rudy Pecci, to whom I owe a great deal, organized a series of webinars on vestibular migraine. We worked in pairs, and each of us had to cover a different topic. Rudy asked me which topic I wanted to take. I thought about it, and this is the honest truth, what was the subject I knew the least about? Pharmacology. So that's how I got into it. It may sound strange, but that's exactly what happened. Then it really drew me in, because I realized it was a topic that suited us well and one that deserves much deeper study, even from a basic scientific perspective. So that's really how my interest began, and it's something I've continued to pursue ever since.
In fact, I've noticed that pharmacology isn't discussed very much at conferences, so I think it's really interesting that you've decided to take a closer look at this topic.
I completely agree. There are very few presentations on pharmacology. You might come across the occasional talk, but not much more than that. I also agree with what you said. At the very least, we need a solid basic understanding, because we prescribe these medications, so we need to know them, including their side effects. And the only way to do that is to study them and keep learning. Fortunately, this is something that has started to receive more attention at our conferences.
It's gaining more and more traction.
Exactly. It's becoming more and more important.
Now let's move on to today's main focus. I'd like to ask you about the importance of taking a patient's medical history as part of a vestibular assessment.
Well, taking a patient's medical history is important in every medical specialty, but in vestibular medicine it's absolutely essential, because in many cases you can make the diagnosis based on the medical history alone, together with a pair of Frenzel goggles. The key is to identify the characteristics of the patient sitting in front of you. By asking a series of very specific, yet simple questions, starting with open-ended ones, you try to understand the patient's condition and guide them toward clearly describing their problem. In vestibular medicine, this is particularly important because it provides the direction for the treatment, whether pharmacological or otherwise.
Of course, in fact, It is well known that in the vestibular field, the patient's history is sometimes even more important than the diagnosis obtained through instrumental tests.
The patient's history is absolutely essential. A classic example is the patient with migraine. As Paolo Pagnini often says, a migraine patient needs to be interviewed carefully. You may ask them 10 times whether they've ever had a headache, and 10 times they'll say no. Then, the 11th time, they'll suddenly tell you that yes, they do get headaches every now and then, perhaps in certain specific situations. In other words, you have to get that information out of them. That's why taking a good medical history and talking with the patient are essential when deciding what to do next. Especially if you're considering medication, along with other treatments, to help solve the patient's problem.
Excellent. Now I'd like to look more closely at the pharmacological side, since this is your area of expertise, particularly in conditions such as vestibular neuritis and acute vertigo. What is your pharmacological approach to patients presenting with these conditions?
Well, in general, when treating vertigo with medication, we have 3 main goals. First, to stop the false sensation of movement. Second, to reduce the autonomic symptoms, since patients almost always experience nausea and vomiting. And third, to promote vestibular compensation. These are the key elements if we want the treatment to be effective. Acute vertigo is the condition we see most often, whether in hospital clinics or private practice, and it's certainly the most distressing for patients. Patients often arrive in a forced position. If they're coming from the emergency department, they're usually on a stretcher, lying on one side, and they've often been vomiting. So the first step is to improve their autonomic symptoms and help them feel better. We need to control the nausea, the vomiting, and the sweating, because otherwise it's very difficult to examine the patient properly. That's why taking a good medical history is essential, but above all, it's the initial approach to acute vertigo that really matters. We need to identify, as far as possible, the cause of the vertigo and understand what triggered it. That's a very relevant question because acute vertigo and vestibular neuritis are among the most common conditions we see in our clinics. These patients usually present with severe signs and symptoms. When it comes to treatment, we have several pharmacological options available. These are first-line medications, but they shouldn't be used lightly. That's why a good knowledge of pharmacology is essential. We have antihistamines, calcium channel blockers, and benzodiazepines, all of which require more specific expertise. Then there are other drugs, such as glucocorticoids and neuroleptics. Antihistamines are commonly used in acute peripheral disorders because they act on the vomiting center in the medulla. The goal is simple: the patient feels very ill, so we need to help them feel better. Patients are often anxious, nauseous, and generally unwell, so there are medications that can be quite effective. Promethazine is one of them. Of course, every clinician has their own preferred approach. Some drugs work better in combination than on their own. Dimenhydrinate and cinnarizine are good examples. We'll come across them again in other conditions. They help reduce symptoms and are often more effective than monotherapy, although they're particularly useful in conditions such as migraine. Benzodiazepines can also be effective, but they need to be prescribed and used appropriately. There's one issue that's still quite controversial: steroids or no steroids. We often discuss this among ourselves. Steroids act as vestibular suppressants and can be helpful in the early stage. But if you use them, they should only be given for a short time. They're not recommended beyond the initial phase because they interfere with what we're actually trying to achieve: central vestibular compensation. Everyone has their own opinion and experience with steroids. They're certainly effective anti-inflammatory drugs, but they have to be used very carefully and in the right clinical setting. After all, there's a well-known reference. A 2011 Cochrane review, one of the most widely cited, not only in vestibular medicine, looked at several studies on steroid treatment and found that the evidence was insufficient to recommend either for or against its use. So, in the end, much depends on each clinician's own experience. But if steroids are used, they should be used in that way. There are also some medications that have been introduced in recent years for vestibular neuritis once the acute phase has passed. These drugs promote vestibular compensation. Some belong to the group of nutraceuticals, although research in this area is still ongoing. So, this is essentially the pharmacological approach to managing acute vestibular disorders.
There's still so much to learn about it.
There's a whole world to explore. Exactly. Then, with experience, everyone develops their own approach and their own confidence in using certain medications. That's perfectly fine, provided they've gained that experience and seen the results for themselves.
So, in the case of acute vertigo and vestibular neuritis, the overall approach is basically the same.
Yes, they are fairly standardized. Absolutely. A patient with vestibular neuritis is very ill. They usually have severe vertigo, they're vomiting, and they're forced to stay in one position. So, in every respect, they're a patient with acute vertigo.
Very clear. Now, what about positional disorders such as BPPV? What role do medications play in these cases?
Well, in positional vertigo, medication plays only a minor role. We know that with BPPV the standard approach is clear: make the diagnosis as quickly as possible and perform the appropriate repositioning maneuver. That's the gold standard. Even so, these patients often feel very sick and may be vomiting, so antiemetic medication can be helpful to make them more comfortable. This is something we've been discussing for many years, the role of vitamin D in positional vertigo. Several studies have looked at this, and we also took part in one many years ago when we were in Genoa. They showed that when patients have a vitamin D deficiency, the otoliths are more likely to become detached, which can trigger a vertigo attack. So, in patients with vitamin D deficiency, supplementation can be beneficial. That's why I always recommend checking vitamin D levels first. When a deficiency is confirmed, vitamin D can become part of the treatment, together with antihistamines. As for other medications, they really don't have a role in BPPV, because the treatment is physical and based on repositioning maneuvers for the different semicircular canals. That's the approach we all agree on.
For example, some patients continue to experience unsteadiness even after their positional vertigo, such as BPPV, has been successfully treated. Is there a role for medication in managing this residual instability after the repositioning maneuvers?
Certainly. Sometimes a single repositioning maneuver is enough, although that's not always the case. It may take anywhere from 1 to 3 maneuvers. After that, some patients may still experience unsteadiness. The vertigo is gone, but they may continue to have dizziness or a sense of imbalance. In these cases, I think there are 2 possible approaches. First of all, you need to assess the patient carefully, taking their individual characteristics into account. You should always consider who is in front of you, because some patients are naturally less likely than others to respond fully to a repositioning maneuver, even when the objective findings are reassuring. Today we also have a number of supplements that can help improve this condition. And if the problem persists, if patients continue to experience vertigo after the repositioning maneuver, or they develop dizziness and unsteadiness, then vestibular exercises can be very helpful. They help patients regain confidence and get used to those movements again. Let me make a quick point here, since we're on the subject. One of the basic principles of vestibular rehabilitation, even in vestibular neuritis, which we talked about earlier, is that the patient has to keep moving. A patient who just sits in front of the TV feeling sorry for themselves will never recover. As much as their condition allows, they need to stay active to help the vestibular system readapt. In a way, you have to reset the system. And the same applies to BPPV, always taking the patient's condition into account. Movement is essential. A patient who stays still will recover, but it will take 3 times longer than someone who keeps moving. Age is another important factor. Older patients are at greater risk and tend to move less. But staying inactive creates another problem: cognitive decline. That's why movement is essential, both in BPPV and in acute vestibular disorders.
Movement is always beneficial.
Yes, definitely, absolutely.
Here's a question I think many people would be interested in. What is your approach to treating a patient with Meniere's disease?
Well, this is certainly an interesting topic, because patients with Meniere's disease are often quite challenging to manage. As we often say, if you take good care of a patient with Meniere's disease, they'll stay with you for life. Meniere's disease isn't something you can cure. It's a chronic condition caused by endolymphatic hydrops. Once again, the key is a very thorough medical history. You need to understand exactly what kind of attacks the patient has and how they experience them. It's difficult because patients with Meniere's disease rarely come to the clinic with obvious clinical signs. Occasionally you may see nystagmus during a deficit phase, but that's uncommon. It's really the medical history that leads to the diagnosis of Meniere's disease. Nowadays, it's true that 3 Tesla MRI can show the high drops, but in everyday practice, the medical history is still the key. So it requires a holistic approach, taking every aspect into account, and above all, a great deal of patience. Because patients with Meniere's disease have to be managed very carefully. When it comes to treating Meniere's disease, just about everything, and the opposite, has been said. There are medications we use, but the evidence for their effectiveness, and for the superiority of one over another, is often lacking. Take beta-histine, for example. It's widely used almost everywhere in the world, except in the United States. In the past it was often prescribed at different doses. Today, the standard dose is 24 milligrams twice a day. It's a complementary treatment. It can certainly be part of the therapeutic approach, and it has very few contraindications. There are also some Italian studies on it. In fact, most patients with Meniere's disease already come to the clinic taking beta-histine. It's usually been prescribed before they see us. Another medication I often see is diuretics. Many patients come to me already taking them. It's a reasonable option, but diuretics are not without their challenges. First of all, they have to be used very carefully in older patients. And here again, the evidence is limited. A 2006 Cochrane review found no strong evidence to support their use, while the American Academy considers them an option for reducing symptoms. Some clinicians even recommend taking diuretics on demand. If you're feeling well but you're going out for dinner, even though you should eat a low-sodium meal and drink plenty of water, taking a diuretic might help. That gives you an idea of just how complex the pharmacological management of Meniere's disease really is. As I said, studies have reached very different conclusions. But the key point is that managing a patient with Meniere's disease requires a 360-degree approach. Here again, lifestyle plays an important role, just as it does in migraine. Daily habits, diet, and for patients with Meniere's disease, a low-sodium diet are all important. But above all, patients with Meniere's disease need ongoing follow-up. They're not patients you can simply discharge. In fact, that's especially true for patients with Meniere's disease.
Thank you very much for this comprehensive overview. One thing is certainly clear: patients with Meniere's disease need close follow-up.
They need to be followed with a great deal of patience. Of course, nowadays we also have MRI, and differential diagnosis remains extremely important. But coming back to pharmacology, we have to be very careful, because we still don't have a drug that can cure Meniere's disease. It would be wonderful if we did, but unfortunately we don't. We have several treatment options, but no cure.
I think the challenge for the future will be to find one, but it certainly won't be easy. You also mentioned vestibular migraine earlier. Is it managed differently from Meniere's disease? If so, how?
Well, let me start by saying one thing. I like to think of Meniere's disease and vestibular migraine as two sides of the same coin. Quite often, a patient with Meniere's disease may later develop vestibular migraine, or the other way around. Vestibular migraine is an extremely common and very challenging condition. For many years it was treated almost exclusively by neurologists, but it's only right that ENT specialists and clinicians working in vestibular medicine manage it as well. It's a complex disorder. In fact, there are medications both for the acute attack and for preventive treatment. Here, lifestyle is extremely important, as are daily habits. We know that several factors can trigger migraine attacks: caffeine, alcohol, artificial sweeteners, processed meats, and poor sleep. So lifestyle and diet play a key role in preventing these attacks. So these patients are often quite complex. In the acute phase, our first goal is always to help them feel better. Vestibular suppressants and antihistamines can be used, just as we do in acute vestibular syndromes, and nausea has to be controlled. There are also many medications available for migraine treatment. As we said before, we could easily spend another half hour talking about them. Some of these drugs are easy to use, while others are much more challenging. As I mentioned, triptans have been used as first-line treatment, although the evidence is still limited, as the American Academy points out. Corticosteroids have been used, as well as promethazine. The real challenge is finding the right medication to help the patient recover from the acute attack. As for prevention, the recommendations are essentially the same as those neurologists use for migraine. Prophylactic treatment is indicated when the attacks become recurrent and the patient's quality of life is seriously affected. 4 or more attacks a month, and acute treatment is no longer effective, the patient is really suffering. That's when preventive therapy should be considered, because these patients are at high risk of a poor quality of life. Several drug classes can be used, including benzodiazepines, beta blockers, calcium channel blockers, and antidepressants. This gives you an idea of how broad and complex the pharmacological management of vestibular migraine really is. Some medications are easier to use, while others are more challenging, without going into the details. There isn't a preferred treatment, because we still lack standardized guidelines. You always have to consider important factors, such as the patient's comorbidities and, especially in older patients, whether they're taking other medications. Vestibular migraine is an extremely complex condition. So complex, in fact, that numerous consensus statements have tried to define the best approach. Even so, up to 2025, things haven't changed very much. At the moment, there are 2 main groups of drugs that are providing encouraging results. One is for the acute treatment of migraine attacks, the ditans. Unlike the triptans, which were used more widely in the past, they're generally easier to use because they don't have the same cardiovascular concerns. It is now well established that the whole process is driven by a peptide called CGRP, or calcitonin gene-related peptide. It triggers pain processing through vasodilation, almost like flipping a switch. Without going into detail, there are 2 main treatment options: monoclonal antibodies, which are now used in many other specialties as well, and the gepants. Several of these drugs are now available in Italy, and they've proven very effective in treating acute attacks. This shows just how important it is to understand both the acute and preventive treatment of migraine and vestibular migraine. Without a solid knowledge of the available medications, we're limiting ourselves and giving up valuable treatment options.
Thank you very much. That was a comprehensive overview of migraine, covering the different treatment options, the various medications, and also the importance of lifestyle and diet in helping patients recover.
As I mentioned earlier, it's important to have a good knowledge of migraine medications. We've seen that some drugs work better in combination. For example, cinnarizine and dimenhydrinate each have some effect on their own, but together they produce a much better response. We use this combination with very good results. And that's an important point. These medications are very straightforward to use, and they should be part of our everyday clinical practice.
Moving on to our final case, patients with PPPD. How do you explain the drug treatment to these patients?
We saved this topic for last, and for good reason, because these patients are particularly complex. PPPD, or persistent postural perceptual dizziness, is a very complex condition. It develops because the balance strategies that patients, and all of us, use to maintain posture are no longer working properly. But why does that happen? This is where normal function becomes the key. Why do these strategies fail? There are many reasons, but one of the most important is the patient's own predisposition. We know that a large proportion of these patients have an underlying anxiety profile. They struggle in certain environments, they feel better at home than in a supermarket or in crowded places. These are patients who may become severely unsteady just walking across a black and white patterned floor. They may also feel uncomfortable walking in the dark. All of this is closely linked to their anxiety profile. That's the framework in which these patients need to be understood. Nausea is usually mild, and there's no true vertigo. So how should these patients be treated? There are pharmacological options. Some patients do have psychiatric features, while others do not. As I mentioned, SSRIs and SNRIs, which act on serotonin and noradrenaline, can be used safely and often improve the symptoms. These patients experience subjective dizziness rather than true vertigo, and the response to treatment is generally quite good. There's one more important point. Treatment can be quite complex. Medication certainly helps, but it's not enough. These patients often need supportive care and cognitive behavioral therapy. Working with a psychologist is essential because the underlying cause has to be addressed. Vestibular rehabilitation is also a key part of treatment. So, if a patient with PPPD also has cognitive and behavioral issues, treating them with medication alone may do more harm than good. You need to look at the whole picture and take a comprehensive approach. And the reality is, we see a great many of these patients.
Exactly. At this stage, it's not just about drug therapy anymore, but psychological care as well.
Exactly. Some of these medications can also have troublesome side effects. That's why it's so important to know them well and to give proper attention to both vestibular rehabilitation and psychological support.
Very clear. Thank you, Dr. Maurizio Bavazzano. Today we've talked a lot about pharmacological treatment while also touching on several broader aspects. For our final question, I'd like to ask for your thoughts. How would you describe the importance of vestibular rehabilitation alongside pharmacological treatment?
Vestibular rehabilitation is essential for all the patients we've talked about. Whether it's someone recovering from acute vestibular neuritis or a patient with PPPD, it's now an indispensable part of treatment. We're fortunate to have many excellent centers in Italy, run by colleagues and friends who do outstanding vestibular rehabilitation. They use advanced equipment, but also very simple techniques that, as a friend of mine likes to say, are within everyone's reach. Vestibular rehabilitation is extremely important because I've seen the results firsthand. I've visited colleagues and friends to see how they work, and they've helped patients who, if you'll excuse the expression, had become severely disabled because they could no longer do everyday activities. And they were able to rehabilitate them. I've seen patients go back to doing things they couldn't do before. Patients who had lost the ability to perform dual tasks regained it. A patient would be walking, the phone would ring, and they'd have to stop to answer it because their brain could no longer process both tasks at the same time. Vestibular rehabilitation is essential. Of course, it has to be based on clear indications. There are validated scales we can use, starting with the DHI, as well as psychological assessment scales. In my opinion, it's an essential part of treatment and something we simply can't do without, provided it's carried out by experienced professionals.
Thank you. Thank you very much. Our sincere thanks to Dr. Maurizio Bavazzano for sharing his expertise and his comprehensive perspective, not only on pharmacological treatment, but above all on keeping the patient at the center of care. We invite you to join us for our upcoming episodes, where we'll continue exploring the diagnosis and management of vestibular disorders, along with many other related topics. Thank you for being with us. It's been a pleasure, and we'll see you next time.
Thank you, Mario. I've really enjoyed this conversation. See you next time.